this partnership and its predecessors, it was important for us to actually get into the social care position and get a better understanding of that. So that's the sort of broad framing for today. I realise that I've said that I've missed out the first 15 minutes where Sarah will talk a little bit about winter pressures in the NHS. So if that's all right, that's the sort of broad structure for today. And I think with that introduction and framing for the day, if we can get into the sort of the meat of stuff. Now, first of all, apologies. I believe I have apologies from Teresa O'Neill and from Paul Bell today. I may also have apologies from Colin Smith. Apologies, Colin, if you are online, but I think I've got apologies from Colin as well. From the membership of the Integrated Care Partnership, I have Norman Lamb, who is joining us online. I think everybody else is in the room today. And Norman, we will make sure, I'll keep an eye on the screen as well to make sure you have a full opportunity to contribute. So with that introduction, maybe if we can get on to the minutes of the last meeting. I'm not planning to do a roundtable introductions. People have their nameplates in front of them, so you can see who people are. So take the minutes of previous meeting first. Does anyone have any comments, corrections, or otherwise the minutes of previous meeting? I don't plan to do a page turn on this, but is everybody happy with the minutes? Okay, that's good. We will take the minutes as being agreed then. Thank you very much. Next item then is the revised terms of reference for the ICP. Now, we spent quite a bit of time on this at last meeting and in some of the precursor meetings to this formal ICP, so I hope there's not too much that people wish to change. We've made some amendments, particularly around the position of Healthwatch, but are people content? I use the word content rather than happy, because you can never be happy with terms of reference. Are people content with the revised terms of reference? Jim.
Just a quick comment, Richard. Thanks very much. Jim Dixon, the Cabinet Member for Healthier Communities in Lambeth. Apologies for the fact that I couldn't be at the first meeting, but I just wanted to acknowledge in 410, thank you to the team for making the amendments I was particularly asking for, which were really designed to ensure that the ICP and the ICB were in lockstep.
Yes.
The ability to hold each other to account and ensure that we were all on the same page on things like performance. I just would want the change in 410, which, as I say, you kindly made at my behest, to be read in conjunction with the minute of the meeting, which obviously did a little commentary on why we were asking for it in 105, and it was very much, as I've said, the reason for that change. And there's a sort of comment about it, and I want those two things to be read together. Otherwise, very happy with what's resulted.
Thank you, Jim, and a good point. Sorry, I should have mentioned that change that was made at your behest, but the intent is absolutely as in the minute. So I think we can take it. Those two things will be read together. Okay, looking around, no other comments. Right. In which case, we're doing very well on time already, which is brilliant. I will ask Sarah now to introduce a short session on winter pressures.
Thank you. So I'm going to give a very high-level overview of the recent and current system pressures across South East London, focusing particularly on urgent and emergency care.
Sorry, you couldn't say who you are. I can't read from here.
Sarah Cottingham, Director of Planning for the ICB.
Thank you.
So our system has faced usual seasonal pressures, but also a number of other issues over the last couple of months. So I'm going to do a brief run through that. I think probably everyone around this table is very aware that we have an urgent emergency care system that's been under pressure for some time, and that pressure is pretty evident across all areas of service provision. 111 and 999 services, primary care, acute mental health and social care. But those pressures have been exacerbated, particularly over the last couple of months, with increased prevalence of COVID, flu and respiratory infections, increased paediatric demand driven by group threat A, and increased overall winter pressures exacerbated by recent and ongoing industrial action in the NHS. So I think these seasonal pressures are being overlaid very much on an already pressured system, and that means that we have had some challenges at securing timely access and flow across the whole urgent emergency care pathway. I think you'll been aware still ongoing significant media coverage of delays and long waits nationally, and we in South East London haven't been immune to that the last couple of months either. So we've experienced some ambulance delays, some long waiting times in our emergency departments, and challenges getting patients admitted and discharged from beds in a timely manner. Paper sort of highlights some of the key areas of ongoing focus to try and mitigate those risks, but also get us in a more sustainable position with regards to urgent emergency care. So each of our hospitals are applying and testing what's called a continuous flow model. So that tries to get the flow from the emergency department right through to discharge. The objective really being to decongest the front door of the emergency department and secure timely hospital handover for ambulances. I think there's huge focus across local authorities and the NHS on discharge across physical and mental health, so ongoing work to try and make sure that we can discharge patients in a timely way, and lots of work on increasing urgent access opportunities with particular focus on the out of hospital care system. So primary care capacity, 111 resilience, but urgent community response expansion, and also the rollout of virtual wards locally. So a lot going on in terms of new models and developing capacity and resilience. Just to note, in December, the Integrated Care Board and our 6 local authorities received additional funding targeted particularly towards social care to help us increase that out-of-hospital discharge capacity, and the plans we put forward in December are currently being mobilised. Then this month, in January, we received through the Integrated Care Board a second tranche of money. That's targeted particularly at 4-week packages of care, and we're in the process of working through how we might spend that money wisely and without duplication. So move on now to groups for pay. The paper does give quite a lot of detail on this, but I won't dwell on it today because it was very much a December issue and is one that's largely alleviated now. But concern about infections grew pre-Christmas, and as a result the NHS across all areas of care saw a big increase in demand, particularly for children, and that was exacerbated by issues with antibiotic supply as well. So in South East London, we created additional clinical capacity in primary care and other settings, made sure we had good information available on antibiotics, and put in place additional lab capacity to get rapid test results in place, and also made sure we were able to provide advice and guidance to public and head teachers as well. So since Christmas, actually, so over the last month, those pressures have been alleviated, so have reduced significantly, but a definite feature and additional pressure over December. As I mentioned at the beginning, we've also seen an increase, as we had anticipated, in COVID and flu and associated respiratory infections. So that's another factor that's sort of driven this enhanced winter pressures we'll be dealing with currently. And last but not least, the system has been working to plan for and manage the impact of a number of days of industrial action. And those have impacted on some of our hospitals on different days, and also London Ambulance Service. So the paper gives a bit of an update in terms of strikes, some of which have already taken place now, that we indicated in the paper we were planning for. But just to summarise the arrangements we put in place for the first set of strikes in December, but have continued to replicate the same model for our planning since. We have mirrored the national incident management team response that's also mirrored nationally in our local system. We have used those groups to undertake detailed planning for industrial action. That does include mutual aid across providers and London Ambulance Service particularly. We've also put in place additional capacity, particularly in the out-of-hospital care space. Lots of communication with stakeholders, public and clinical staff have been providing support into the local London Ambulance Service Control Centre on strike days to help with triaging and managing of that demand. The RCN strike particularly, but strikes have resulted in some cancelled outpatient and inpatient activity. We are collecting that, so we have that information available post each strike day, but our approach generally is to keep that to an absolute minimum and minimise the disruption to patient care, and a particular focus on retaining emergency services or emergency or life-saving services. So the paper refers to derogations which were agreed before each strike, which essentially make sure we have numbers of staff available to continue to do that emergency and support work. Probably worth just highlighting, we still have more strikes taking place and planned for this month and into February, so we'll be adopting that ongoing approach that I've described already. So I hope a helpful overview of the system pressures, some of the specific incidents which each of the organisations I think have been trying to deal with over the last couple of months. We did receive a question about performance as well, and associated performance on some of these key urgent emergency care metrics. That is published nationally, and we do provide it for our integrated care board meetings as well, but we can replicate here going forward if useful.
Okay, thank you very much. So just before I take I should have said at the start, I apologise, that we are recording this meeting, so I should just, and that will be made available online, so just so people are aware of that. So thank you for that, Sarah. Any sort of questions or comments? A couple of things I wanted to raise myself. Okay.
Jill Lockett, Kingside Partners. Thank you, Sarah. It's a really helpful report. I'm just aware that there's a number of GPs and other clinicians from across the system who've been supporting the LAS HQ during the strikes, and I think there's potentially quite a lot of learning about care pathways and how we might take some of the learning from those sessions to look at our care pathways locally, potentially around community services and our wider offer. And I just wondered how as a system we might respond to that.
Okay, I'll collect if there are other questions as well, Jill, and I'll work my way through.
Folake Shegun, Director, South East London Health Watch. Again, thank you very much, Sarah, for that. Just going back to that comment you said you received around metrics. Does that mean you will be publishing local data alongside minutes, perhaps, so that there's more clarity for the public about the effectiveness of the plans and the things that have been put in place?
Okay, I've got to. Is there, Jim?
Yeah, just it may be a statement to the obvious, but I do think it is worth putting on record on the additional money that the government's provided to deal with the urgent winter pressures, that giving us nationally 200 million and a smaller sum for the ICS to be spent by the end of March really isn't particularly helpful. I know that obviously we locally were doing our best to ensure that it's the benefits are maximised, but we would be much better off getting that money over a longer time frame so we can invest in permanent additions in capacity, which will prevent next year's winter pressures and the winter pressures thereafter. So I know that people are saying this, but I think it's worth putting on record that we'd like the view passed up the line that actually a more effective use of money is long-term investment rather than quick tranches of money which actually aren't easy to spend in highly beneficial ways for the system.
Thank you. I can see Mike actually. So Mike,
I wondered if it'd be helpful if I sort of illustrated Sarah's points by giving you a sort of 10 picture of the microaviation Greenwich Trust.
So what I'll do, if I give an hand, get people just to answer the questions down, then Mike, bring you in on that, because I think that is useful to try and get a picture. Will you want to come in as well, Kieran?
Yep. Thank you for the update, Sarah. And I suppose from all of us, we want to say a particular thanks to all those staff who are working very hard and with a very difficult system at the moment to make sure people can get the care that they need. You outlined very specifically the pressures on the NHS side, but I know from previous conversations that's flowing through into social care just as much, and we have our social care teams working incredibly hard to support people coming out of hospital, back into the community, and indeed must need to go into hospital as well. And I really want to just echo Jim's point that it is a good thing that we've got temporarily some money to support this work, but this is a long-term effort and it's not going to turn around overnight. And I think people across our communities are very, very concerned right now about the ability to A, get emergency care when they need it, and B, get that long-term treatment when they need it and not be on a long waiting list. Bringing that down is a real priority for all of us. But we need that long-term funding in order to be able to put in long-term responses to that across our hospitals, our primary care, our social care.
So I'm going to try and pull some of this together, but I also realise that I've got a hand up from Norman, because the virtual hands I don't think are working on this. So although I keep saying I'll pull the question, give me a minute, Sarah, I'll let Norman come in at this point. Norman.
Thanks very much. Can you hear me?
We can't hear you for some reason, Norman. I don't. No, it's not on you. I think there's a. I think we may have a problem with technology.
Very happy to wait.
Whilst we try, whilst we try and resolve this, Norman, do you think you could write it in the chat? I'll pull the other questions together, Norman, and then we'll come back to your one in the chat. So just so I don't forget them, there is the question on learning about our pathways, particularly from how we've handled things in the strike action. That's something that a lot of us have discussed. There's a question on the publication of performance information at a local level. There's a whole sort of question, I guess, the link questions of the short-term funding and the sort of more longer-term strategic approach to funding, which I'll probably try and take myself and then pass on to Andrew. But maybe on the first two, if you could take the first two, Sarah.
Yeah, so I think we have tried to do two things coming out of the industrial action. One's of overall learning, so each organisation has done their own learning, and then at the system level, I think that has been as much about process impact, but equally to pick out key areas where there is learning from a care pathway perspective. And I think one of the major ones is around ambulance service conveyancing, and the learning from how control centres were managed on the industrial action day. So quite a lot of thinking. I think John T has been involved in London-wide and local discussions on this to think about how we pilot some of the approaches that we adopted on those days, with the objective really of making sure we are effectively managing demand, conveyancing and optimising these alternative services as well. So definitely noted and work in progress. In terms of publishing data, well, there is national data available that is by organisation, including for LAS and hospital sites. As I said, we do provide that to Integrated Care Board, but we can equally provide this.
If we could, I mean, particularly, I guess, from a Health Watch perspective, so you could actually make sure you have that data, and that's you're asking for above a level, I guess.
Yes.
Is that what you're?
Or our local providers.
Or your local providers.
Yes. A lot of information isn't at borough level. For A&E, for example, it would be by A&E site, which would encompass total flows. So it will be a combination of what's available at by site, by hospital, and at population level. But we can make that clear in the data.
Okay, if you can make that.
Then I was just going to say on the funding. I mean, I think we'd all agree that knowing money up front and being able to plan effectively for it gives us the best possible outcomes. And I think all the money I've referred to has been made available nationally, so it's out of our hands. But I think definitely something we need to raise and possibly when we plan and risk-based approaches as we plan going forward.
Thank you. Just on that money point, in the presence of my Chief Financial Officer, that never likes me saying this type of thing. This sort of happens just about every year I've been involved for the last 20 odd years, that something comes late in the year and everyone then grumbles about it's too late to be able to use it for. And it's one of those things that is sort of recurrently non-recurrent. Yeah, it's always there, and I think there is something in our financial planning that we really need to think about whether we do make a more risk-based approach to making some assumptions about what might happen, and we may get it wrong, and that may then give us problems later on in the year. But it's probably better than us doing what we do now. On that point, I was going to try and get Norman. I'm told, Norman, we might hear you.
Can you hear me?
Norman, thank you.
Just after I put a long message into the chat, but never mind. I just wanted to alert people to the fact that I'm currently chairing a sort of pan-London time-limited board looking at the urgent and emergency care system for people who experience mental health crisis. And we know that there are significant issues, particularly about people getting stuck in A&E departments for many hours, sometimes for days, massive implications for acute hospitals, but also for police. And we're aiming to publish what we're calling a crisis care concordat, hopefully bringing together local government, mental health system, acutes, police, user groups to sort of commit to a small number of key objectives to try to improve the way the system functions, particularly reducing the use of Section 136, which results in significant numbers of people being conveyed to A&E departments by police. So it seems to be going quite well. There seems to be a lot of buy-in, but I just wanted to alert you to that work. It also in part depends on us being able to work more effectively with local government to enable people to be discharged on a timely basis so that we can free up space for people who are in need of urgent admission. Thanks, Richard.
Thank you, Norman. I wonder whether this concordat is something we could potentially sponsor as an integrated care partnership within South East London. I mean, given it needs the conversations with all the stakeholders, but it's the sort of thing that I guess the integrated care partnership. This is a place where we bring lots of organisations together.
We're very much hoping that all the ICBs sign up to it so that we have system buy-in. We're trying to do it very much through collaboration. We've had representatives from all the ICBs at the meetings that we've been holding on it. And the aim is to achieve a consensus, which then enables us to, in a way, hold everyone to account on the commitment we make to improve the way the system works. It's not rocket science, but just by way of example, we've uncovered the fact that there are over 6 more than 6 days across London.
Yes, we just lost your sound when you gave us the numbers there, Norman. Sorry.
Over 600 people across London who are in inpatient care for more than 60 days, which we know is generally not good for people. And if we can improve our timely discharge and ensure that admissions are purposeful, then we can improve the flow of people through the system and make beds available for people in crisis.
Thank you very much, Norman. And we look forward to seeing the draft concordat, I guess, both here and our individual organisations. Charles, you wanted to comment at this point. Now, I'm going to bring you, Mike. I've not forgotten you.
Yes, Charles Alexander, I'm the chair of Guy's and St Thomas's and King's College Hospitals. I just want to applaud this initiative that Norman has just described. As he points out, it is a considerable strain on the A&E departments of the big provider hospitals. I'm sure Mike will confirm this as well from the provision point of view. And it's damaging from a number of perspectives, including safety, patient safety in A&E, and also it's not good for the patients, the mental health patients themselves, from the A&E perspective. And what he says from the point of view of long-term inpatients in needing better flow through mental health treatment is definitely the case, and how one brings together the acute providers and the mental health trust in this area is a matter that I think the PICS should take a very close interest in.
Thank you. Thank you. Now, Mike, I am going to bring you back for your pen picture of Lewisham.
Yeah, I just thought it might be helpful to illustrate some of the points that Sarah really highlighted very effectively in her report. And this is across Lewisham, University Hospital and Queen Elizabeth Hospital. Something about the level of demand. If we look back to December, typically we would see around 400 A&E attendances at Lewisham and somewhere in the region of 450 to 500 at QE. During most of December and indeed on 3 consecutive days in December, we saw 1,200 plus. So that gives you a bit of a scale. It's always busy in December, but it was 20% or more busier than we would normally see. So that gives you a bit of a sense of the scale of the pressure. I want to say something about the impact of delayed discharges. So we've currently got the equivalent of 4+ wards full of people who are ready to discharge. That's about 1 in 5 of our bed base. So that gives you a sense of the challenges we have around delayed discharge. I'm sure Andy might want to say something about the problems around ambulance handovers, but that is a major issue for us, and I have to say we're contributing to the challenge for LAS in terms of meeting their targets by very substantial delays in handover patients. Often as many as 12 patients per day, at each hospital are waiting more than an hour for handovers, sometimes considerably more than that. If I look at the impact of the strikes, both of our hospital sites have not been impacted directly by the RCN strikes, but they have been providing mutual aid, as Sarah said, to Guys and Tommy's Kings and the crew. The other area I thought it was worth touching upon is all of this is happening. We talked about the flu impact and the COVID impact. At this time of year, we would normally have around about 500 staff per day off sick. We're currently over 700 staff per day off sick. So that gives you an indication of the additional pressures that we're facing on the workforce front. But a little bit of hope. So Sarah also talked about some of the initiatives which are being pioneered, and at QE Hospital we've been operating what was formerly called the North Bristol model. It's now called the Woolwich Way as far as QE is concerned, which is actually helping us to manage some of the pressures in the ED department. With those numbers it's very difficult, but what ultimately we're doing is we're taking people out every hour or so from the ED department and putting them in wards in areas where we know there will be vacations, there will be vacated beds later in the day. It's a real challenge for our staff, but it has been making a difference. And one of the really important things there is we have really set a difference in terms of getting people home by lunchtime. We've had a 10-fold increase in the number of people who are home by 1 o'clock in the daytime, as opposed to much later in the evening. We know that's really important for people's capacity to settle in back at home and their overall well-being. So just wanted to give a flavour of what it feels like on the front line. So,
I am going to take one last comment from Tal. Introduce yourself, Tal, and then I'll have to wrap this up.
Thanks, Richard. I'm Tal. I'm the Director of Voluntary Sector Collaboration and Partnerships. I'm aware of all those challenges. I think everyone in the country are aware of those challenges. I think we need to think a little bit more creative. Here representing obviously the voluntary sector, there's a lot of innovative ways that the voluntary sectors can be part of the solution of this problem. Particularly around hospital discharge, and particularly if you're thinking about mental health and discharge into community, you don't want people spiraling into that crisis point. You want to prevent before they're getting into this point. And I think some of the initiatives that we got locally and that we got across London and in the country, we can utilise here to prevent kind of that crisis point happening in the first place.
Thank you very much, Tal. And I am going to bring my Chief Executive in a minute, but I just want to pull everything together a little bit on this. So I think we all recognise it is hard at the moment, it is tough, and there are lots of factors at play on this. But I think also as a partnership board, what we need to be clear about is, well, what are the things we can do about that? If all we do is sort of crank the handle in the same way every year, we'll frankly be back here again next year and the year after and the year after that. So really thinking about, I guess, types of things you've talked about, Tal, what we can do maybe differently on the planning side around working with social care. Some of the things that Mike's also talked about are more all sort of stuff. Norman's been on the Concord. There's lots of things that can be working here that help ease this pressure. And I think as a partnership board, that's what we need to focus on. So I think it was really helpful. I'm going to give the last word to my chief executive, because any time I mention anything about committed money, he whispers in my ear and says, "Could I say something at the end, please?"
I do want to say something on money. I also just wanted to say what I thought this group of people could contribute that other forums can't, because we discussed this, obviously this agenda-based places we go, and for obvious reasons. Just on the money, if we can sort of convey messages externally, recurrent, non-recurrent or otherwise, I mean, it's just the fact having longer to plan usually gets a better outcome, there's no question about that. I think also the specification of how it's used, given we had a chance about this a week ago, over-specification doesn't lend itself to local solutions that are going to work best for us. So I guess that would be my second message if we were to have this time again, that we would locally determine it. And then also, I guess, I don't think we're victims of our own success, but we are performing comparatively well on some measures, and consequently some of that money, although it's recurrent each year, is then targeted to places that perhaps need it arguably more, I might argue less, but nonetheless. So there are just a few things around certainty that I think would really help. So there's sort of messages if we were to have our time again there. On the Mental Health Concordat, I think we absolutely should sponsor that as a system. It's not a but, Norman, just so you're clear, I'm just very aware that it is a London Concordat, so achieving it is a different task for each part of London. And what we're trying to get to grips with now is why is it we've got such high levels of demand, at higher levels of demand than other parts of the capital. So I'm not comparing us to Sussex or Gloucester, but just other parts of London. There is a greater level of demand, and we need to get under that. I think that analysis coming back here and understanding would be really useful for partners to make the best response. And then just a couple of things that I think are predictable ahead of time. The care home markets, if I'm probably least qualified, and we've got Sarah's going to talk about social care later on, and early thought, is there more we can do to make sure that is a vibrant place for the workforce as much as capacity. And then just in the last week, the message, and so all those providing community services, and then relating it back to what Andy's team might have experienced at LAS, not having a consistent offer, some level of consistent offer in community that's well known to everybody in each of our boroughs is a real rate limiting factor if you're trying to use alternative ways of not using an ambulance or getting to a hospital. And at the moment, I have been, and we are an advocate of localism and place, but we do need to sort of try that balance around this table. What is a consistent offer that will work everywhere, and then what are the genuine nuances we need, because we're not unique in this, but our system is getting on for one when no one of our providers, and Mike no one of our providers is just treating one borough. Across several, and I guess across the Thomases, you're probably related to 14, 15 boroughs at any one time. So some level of consistency, a bit to Norman's point on a concordat. It's not a concordat clearly, but what is the things we can expect everywhere, and then what are the genuine meaningful differences? And I think that would again be a good debate for us to have here.
Thank you, Kieran. Yeah.
This is a really important discussion. It's obviously really important that we're having it here, particularly because it's a public forum. I guess my ask as we come back to it, and we will want and need to come back to it, is that we come back not just to the pressures in the hospitals, but also the social care, the voluntary sector, the general practice side of it, and look at things in the round, given that is our role. But I absolutely echo your point, Richard, about can we then come back to the practical and what we can do. And Norman, your protocol I think is a really good example of one part of that, but my answer would be that each time we're coming back, we're looking at what is another area where we collectively as partners can make a difference in changing this, if we get roll our sleeves up and make that particular idea work.
So can we, just on that, can we come back to the next meeting where we do try and sort of wrap this together a bit more NHS, because we've got the NHS piece, we've got the social care piece separately today, the NHS social care and voluntary sector piece, and then think about, again, what are the things potentially uniquely as this partnership we might sponsor and progress and commit to that would make this different next year, and not try and sort of do everything, but are there 2 or 3 things that we can go back with that only we as a group can really sponsor? If people are happy with that, we'll sort of make a commitment for that for the next meeting. Thank you. Now, I have let that run 5 minutes beyond my time, having thought I caught up a lot at the start. Unsurprisingly, that took quite a lot of time, but quite rightly. So I'm going to move on to the integrated care strategy discussion now. Now, you remember we had sort of quite a discussion at the last meeting about agreeing our priorities. This has been built up from a lot of engagement over the last 6 to 7 months. What you've got in front of you now is a draft publication of our strategy. Now, I'm going to ask John to speak to that in a minute, but I also want to use this session then, as I said at the start, to also drill down a little bit into some of the work specifically around children's and young people's mental health. So, John, can I ask you to kick off on the strategy itself? And we assume everyone's read the document.
Yeah, yes, absolutely. I won't do a page turn on it, but given that we're also quite short of time. Thank you, Chair. Yeah, so I'm John T. Heversage. I am Joint Medical Director for the ICB and have had the great pleasure of working with many of you and the team over a number of months now to get to the point that we are at today. We had a long conversation about this at the last meeting, so I'm not intending to go over all of the detail that we did previously, but I just want to highlight a little bit about the process and the next steps, if that's possible. I'm going to use a couple of slides just to help as a bit of an aid memoir. So move on to the first slide. I think the first thing for me to do really is just to say a huge thank you. Thank you to the team in the ICB who have done an enormous amount of work on this over the last few months. Also our sponsorship group who have offered us insight from our partners across and direction from our partners across the sector. But of course members of this board and the public who have participated very, very actively in the engagement process that we've undertaken now, as I say, since last summer. It's been incredibly important, and certainly from my point of view, I think we've said from the outset that the process around this is as important as the product. The opportunity to have a conversation as we've transitioned to a new organisation in the ICB has been incredibly important. So how have we approached this? People will be aware that we have tried to understand in quite some depth the need within our population by both looking at the data that we have around that, and great thanks to our public health colleagues who have of course been able to give some direction around that, but also looking at the strategies that exist in each of our places and our provider organisations, trying to have conversations with our communities about what it is that matters to them. And we tried to bring together all of that insight and all of that intelligence into a significant number of engagement events over the summer and the autumn to identify a set of a small number of priorities that we could all commit to. Those were tested against criteria that we established together, and those criteria were really about what is it that will make the greatest difference to the population, but equally, what is it that will be best done together. So what we're not trying to do in this strategy is to identify everything that's going to be happening in our system as we go forward. There will be a number of other plans and strategies within places and provider collaboratives and individual organisations. And of course, we have our own operating plans and we have our shared forward view going forward over the next 5 years, which will define a range of other things that we will need to do as a partnership. But very much for this partnership, we wanted to identify a small number of things that collectively we would really focus on over the coming years. So that's why, or is, I guess, the context of the strategy. The next slide really kind of highlights where we have got to and what has been shared with all of you in draft. And essentially that gives you an overview of the process that I've just outlined. It gives a statement of our mission, why we're doing this, and our vision for future health and care systems. We've identified within that the key priorities through the engagement process, 5 strategic priorities, why we've chosen them, and how we're now going to progress those. We've also tried to highlight, at least at a high level, a little bit about the how. What is it that we need to enable that change to happen in our system? And of course, that will now be published on the 2nd of February on our website, assuming that the board is supportive of that today. So it is still, I guess, important to say that there's detail that will need to underpin some of those priorities, but I just wanted to highlight where we've got to in terms of our vision and those key priorities. So the next slide is really just highlighting the vision, the 6-point vision that we've got to. This, from my point of view, is critical because essentially it's this that will unleash the energy within our system, within our frontline health and care professionals, and within our communities, recognising that these 6 attributes, if you like, of care are what we are focused on as a system, ensuring that as a system we focus on health and well-being, on convenient and responsive care, on whole person care, on tackling health inequalities, on doing that in partnership with our staff and our communities, and on securing sustainability in the system. So that is what collectively we have agreed is our vision, and as I say, very important that we think about how we communicate that and connect those within our system to that vision so that they feel empowered to be able to start to deliver change and to innovate to support some of that. The next slide really just highlights those 5 priorities that we have arrived at. So prevention and well-being, thinking about how we prevent ill health and help people to stay well. Support in the early years, ensuring that children get a good start in life and there's effective support for mothers, babies and families, both before birth and early in life. There's a second, children and young people's priority, which very much reflects the conversations that we have with the public, which is around thinking about children and young people's mental health and improving that and ensuring there's quick access to support for children and young people who need it. Equally, and perhaps this touches on the previous conversation, there was this very, very strong recognition of adult mental health. And so that forms the 4th priority area for us, ensuring that adults have access to the support that they need to support and to prevent some of the mental health and mental illness that we see within our communities in South East London. And finally, there's a priority around primary care, something we've heard a huge amount about, both ensuring that it's convenient and accessible, but also that we support those people who have long-term conditions to have continuity of care and clinician through that process. The final couple of slides I wanted to speak to are really just talking a little bit about how and the next steps. So we've identified that in order for us to do this, and this is still quite high level, we need to do more detail on what these enabling capabilities are in our system, but we will need to plan and work together. So partnership working really is the foundation on which we will need to build and progress our strategy. We will equally, and we'll be talking a little bit more about this further on the agenda, we'll need to think about how we allocate resources in a way that reflects these key priorities. How we build leadership and capability that can work across organisational boundaries, and that's something we've already started in South East London. How we do this very much in partnership with communities, so ensuring that around each of these priority areas we're working in genuine partnership with health and care professionals, but also our communities and service users. How we create the conditions for innovation and change within the sector, and how we think about developing our digital capability and our estates to reflect some of this. So those are the key things that we know we're going to have to focus on if we want to make any of the change that we've just talked about in those 5 priority areas. So in terms of the next steps then, we hope to publish the strategic priorities that we've identified, but I think we very much recognise that this is a milestone, and there is then further work to be done through the spring to be thinking about the how in more detail. So working with reference groups, small reference groups, to help us understand what outcomes and targets we want to achieve, how we want to really refine the problems that we want to solve around those key areas that I've identified, how we ensure that we do that with our communities, and how we start to develop an approach to delivering on those priorities. And that will require us to be, I think, much more precise. At the moment we have a high level ambition, but we need to now really start to flesh out the how. in more detail, and we will bring that back to the next partnership board meeting after this. So I think just finally then for the partnership, we would welcome immediate reflections on the document that's been shared, of course, and also any guidance in terms of what you would expect to see in the next phase of the strategy work. And we will of course continue to bring reports back to this group as the leading group for the strategy in the ICS.
Thank you, Chelsea. Now, I'm conscious of time, and we have been through the priorities a number of times. So I guess what I'm saying about here at this point, before we bring Martin in on children and young people's mental health, is just any sort of immediate reflections. I think that we really need to move this on to the concrete phases of, right, these are the priorities, what are the actions, and what are the ambitions that we need those actions to live, which I think we need to come back to really at the next meeting. But in terms of sort of broad thrust, does this reflect what you expected as a partnership board from our previous discussions? Any things that, I guess my initial thing is anything that particularly jar with you at the moment, or things you just don't feel quite right to you? Jill.
Thanks, Richard. I think the document reflects all the conversations we've had actually, and I'm looking forward to the conversation about delivery and timelines. And I think it is important that we get some timelines associated with the document, because there's not a lot to disagree with in the document. But just wanted to commend the team. I thought the document presents the story of the strategy incredibly well, and I thought it represented the inclusive nature of the conversation.
Thank you, Jill. I agree entirely on the sort of timelines milestones. Now, Norman, you would like to come in as well. Hopefully we can hear you.
Can you hear me? I hope you can hear me. Can you hear me? You can hear me. Good. I think it's great. I think I commend, as Jill does, the work of the team in getting it to this point. Very grateful for that. It's just, I suppose, a point to make that I hope we, in a way, embrace the opportunity that we have here with the ICS to be ambitious in our thinking, and to recognise that if we don't start to tackle the social determinants within the priorities that we've set, then we will fail to really move the dial on much of this. And I'm thinking in particular, for example, of the link between money and in particular debt and mental will help the team in some cases. And they're dealing with 5 people a week who come to them with literally no income at all. And if we think about the impact of the cost of living crisis across our communities, this is really significant, and we need to make sure that we're within our priorities, that we are embracing the need to confront some of those social determinants rather than narrowly looking at delivery of health services.
Thank you, Norman. And I think everyone would agree with you about the level of ambition, and particularly I think about, we don't just want to focus on delivery of health services, because we can do that in a different place. This is about trying to do something quite different. So that should, as we go through this next stage of the reference groups, we really set the actions. I'll be looking to Tal and voluntary community sector colleagues amongst others on this to really try and look at this quite differently. Splaki, you had a comment as well.
I did. Again, I wanted to commend the team. I know a lot of work has gone into this, and commend the engagement with members of the public. 6 months of ongoing conversation has been very good. I'm very hopeful that that will continue as the time pressures to deliver a strategy before June, alongside a 5-year forward view and alongside operational plans. I'm very hopeful that engagement with partnership with communities and staff who are also members of our communities continues and remains strong. And it would be good to bring some members of the public into the visioning around the reference groups as well, and just make sure that they're involved in that. You know, I know there are programs of work, and we're going to hear about the Children's Transformation Program. It would be really good to hear how the voice of people are in those rooms.
Thank you very much, and again,
But great work.
anything I would disagree with there at all. Kieran?
Well, I want to very strongly agree with you, Norman. You know, it is. I think this is a great strategy. I'm really glad we've got this focus on mental health so strongly in it. That certainly comes through from my community as one of the biggest priorities across all issues, not just talking about health and well-being, but mental health has come across really strongly. And of course, we need to make sure that we've got great mental health services, and we're doing fantastic work already in increasing access, for example, to children's mental health services. But we've also got to address the root causes of that mental health. And Norman, you're absolutely right about poverty being, you know, the biggest driver, I'm sure. So I think getting into that's really important. The other thing I want to say, I just really want us to seize the opportunity of the expertise we have across our community, and you know, we have this fantastic opportunity here to bring together the lived experience of our residents, the amazing universities, people having impact on urban health, with the expertise of our frontline workers and voluntary sector, to really push our knowledge and understanding of how you make this impact. And so if we're talking about mental health, you know, we want to get beyond that international focus on just giving people pills to work out, yes, drugs are the right thing for some people sometimes, but actually what are the other things that are going to be really impactful. So I really hope in these board meetings in the future we're going to be bringing in that expertise from our residents, from our academics, from our frontline services, to say how can we have a really deep impact on these priorities.
Jim?
Really quickly, because I know we want to get on to the broad discussion, but just to say again, I think it's been a really good process, a very inclusive process. I think we're all absolutely signed up to the objectives here. We had the good fortune in Lambeth that we were reviewing our health and wellbeing strategy at the same time as this being put together, so they really dovetail well. And I think there is a message out there to component parts of the 6 boroughs and all the other component parts that we need to make sure our own local strategies absolutely do dovetail with the wider ICS strategy going forward. And just the point about delivery, I mean, I think it's been made, but it's worth saying again, I think it should be about additional and extra elements of being able to bring the wider system together rather than duplication at local level, because I think we all feel that with the right support we are doing some really good things locally, and the ICS should be there to promote and enable those as far as possible.
So with those 2 points to conclude, I think, John, for you and the team, particularly if you get into this sort of reference group work, and bringing in sort of Norman's point as well, this is, as we get into the sort of the ambitions, the targets, the actions, being very clear in our reference groups that we want to bring together, the full heft of South East London on this. You're not just a small team. This has got to be getting everyone on the design here. It's got to be about doing those things that only we can do together. That is not about duplicating what's being done already, and has a real level of ambition. Now, if we can sort of come back with, well, what does this start to look like in terms of a programme of work with sort of specific timelines? That's, I think, what we've got. But thanks to all from the team for the work they've done so far. I'm sort of consciously watching the clock again. I'm 10 minutes off, but that's all right, Martin, because I'm still going to give you your 15 minutes on this, so we're not going to cut down that time. I'll try and squeeze something elsewhere. But Martin, can you introduce yourself as you take us through the sort of young person's mental health transformation approach?
Sure, thank you, Chair. So my name is Martin Wilkinson. I work for the ICB in Southwark, where I'm here because I'm the Senior Responsible Officer for CYP and Mental Health Transformation, working with colleagues across our system in South East London. I'm joined by Rupi Dev, who works very closely with me in the ICB on those issues as well. So thank you, Chair. So today I brought a summary update of our focus on CYP mental health and emotional wellbeing transformation across South East London. We have been doing lots of work over, well, many months, but at least in detail over the last 6 months, working through our places and our providers. So lots and lots of patchwork work has already happened and started around children, young people and mental health. already, because we've been working to update a transformational plan which is focused on actions and interventions for the next few years. So it's not a strategy, it's a plan of delivery for the next couple of years. It's currently in draft. It has been developed through our partnerships, so it's been and endorsed through our 6 local care partnerships already. It's been to our South East London Mental Health Transformational Board, but it's yet to come to the Integrated Care Board for final sign-off. So it is very much still a draft, but it will go there shortly. It focuses on key interventions that we are intending to do and have started in some cases already, around 10 key priority areas which are listed in the paper, which came out of some work we've done previously on how we might address children and young people's mental health inequalities, which is very prevalent across South East London. We're very focused on finding pragmatic and practical interventions that can support and reduce those inequalities across South East London. The interventions against those 10 key areas are listed in the paper, but just to draw some out, there is action going on to reduce waiting times, particularly for children who are waiting for CAMS services, so our secondary care, child and adolescent mental health services. There is work already started around prevention, both led by each of our 6 places and local authorities, and also work that we've been working jointly across South London on with our communities to pledge and commit to some actions around prevention and early intervention. So South London Listens, which obviously builds in some of the discussions and the bits about wider social determinants has come up very strongly through that programme, which Norman mentioned earlier. We've also started to action further support for parental mental health, because we recognise that parents having good mental health also supports children with their mental health as well. With further rollout of some support across South East London. We're increasing our work with our schools, both primary and secondary, through our places, and work with primary care to see how we might alleviate and support people with mental health and emotional wellbeing issues. But I have to say the current plan does focus heavily on sort of secondary and tertiary services, so it does talk a lot about prevention and intervention, but we do know that actions in this area are light at the moment. So I think it is a great opportunity to connect up the strategic priorities that Jonty talked about earlier, which do focus on prevention and early intervention, both for children and a separate strategic priority for adults as well, because we recognise there's something about the family approach to early intervention and emotional wellbeing support for families and continue to work with our communities to build support, community resilience, work with voluntary community sector. So I think there's a great opportunity for added strengthening of the plan and linked to our strategy and ambition through further conversations and discussions through the partnership. We have posed some questions within the paper or in section 3.1. I wasn't particularly going to read them out, but I think for me it is about how the partnership working together can add value to our ambitions and scale up the work we're doing and strengthen the work we're doing. There is lots and lots of work already happening in our local care partnerships, through our health and wellbeing boards, through local partnerships on the ground. So I think for me, there's something about actually the interventions that we might do across South East London collectively, which might not happen the same way in every single borough, but we have some consistency of our offer, because for me that's an important thing to get right, so we can be confident when we say to our families and children and people that this is what's on offer. It might be provided differently by each borough, it might be slightly different, but actually gives a level of consistency, particularly around prevention and intervention. And we continue to work between secondary, tertiary services and our voluntary community sector, social care, councils and our communities to deliver interventions that support them in their start of life and as they go through their life. So, Chair, very happy to answer any questions along with Ruthie or take any comments. Thank you.
Okay, thank you very much, Martin. Now, I know Norman has got his virtual hand up, so I'm going to go to Norman. I have got Mike. I'm looking to my left, I've got Tal. So let me take those 3 first of all. So Norman, you're first.
Thanks a lot, Richard, and thank you, Martin. I massively welcome the work that Martin and others have done, and I think it's absolutely in the right direction. If I could just make some offer some quick fire thoughts. First point is I favour sort of fundamental system redesign rather than tweaking the current model. As Martin says, we focus hitherto on sort of improving the current secondary care system, but to me the CAMS model is quite broken and dysfunctional and fails too many families. So I would urge us again to be ambitious. Second point is that I think as far as possible we should be trying to base our approach and design on evidence of most effective interventions and approaches, being prepared to look both across our country but also internationally for models of best practice. Other countries
you've suddenly you paused then when you just talked about the international stuff, Norman.
Can you hear me now?
I can hear you again now.
So other countries are ahead of the UK in terms of redesigning how we respond to growing youth mental ill health. So I think we can learn from what other countries have done. The next point is that I hope very much that as we move forward, we involve young people in our design work. Within the sector, it's sort of recognised that you really have to talk to young people and get their perspective in terms of how we design the system to meet their needs. The third point is that, or the next point is that I was pleased to note in the finance paper that there is a recognition of the need for more investment in children's mental health. It has been under-invested nationally, but also within South East London, and we need to make sure that we stick to that sort of commitment to address that. Next point, I note the suggestion of trialling transition workers to support young people as they move from youth services to adult. My very strong preference is to move to a 12 to 25 service rather than try and employ more people to help effect a transition at 18. It's fundamentally wrong that we are trying to shift people from a youth service to an adult service at the age of 18. There should be continuity of care at that age, and that's recognised again internationally and in some of the more advanced areas of the country on the design of systems. The penultimate point is we must remember the role of digital. I should declare an interest. I'm an advisor to COOTH, but COOTH is already funded. This is a digital platform for young people. It's already funded across South East London, but we need to make sure people are aware of it because they can get access to almost immediate counselling online rather than the very long wait. It's not a solution for all, but it should be an embedded part of the architecture, whoever is the provider. It's really important that we embrace the role of digital. And then finally, EPIC, I noted that EPIC is mentioned. This is stands for Empowering Parents, Empowering Communities. It's an evidence-based model. It can be used both in teenage years, but also in early years. And I really would encourage the ICP to think about the importance of intervention in early years, parenting support, and this EPIC involves parents in how the approach works. So it is genuinely empowering of people and communities. So if we did nothing else, ensuring that EPIC was available for all at-risk families across South East London would be a massive advance on where we are.
Thank you very much, Norman. There's an awful lot there, and clearly you have a lot of knowledge and and experience in this area. And whether we'll be able to answer every single question in the time we've got.
I don't know.
Yeah, I think we'll. But I think this general challenge to us, Norman, of the improving the existing model or breaking the existing model or accepting the existing model is broken and doing something quite different. I think that's the sort of big question on this, because I'm nervous about just saying it's broken, create something new, rather than, I guess, the saying we've got to try and make the existing system work as well as possible at the same time as creating something new. And that's, I guess, the balance maybe the team are trying to strike in this. I'm going to take Mike, Tal and Kieran, and I'll probably try and pull it together at that point. Mike.
So yeah, I want to echo Norman's positive comments about this piece of work. What I'm really keen on is that we link it across to some of our other strategic goals that we've just signed off, particularly the early years, the best start in life. And that actually links across to some of the services that my trust is responsible for. So there is something about making sure that we can get women access to perinatal mental health services when they need them, because we know that the absence of those will have a long-term impact upon the mental health of their children. Similarly, we need to be making sure that we are promoting and developing those community partnership models around things like breastfeeding, because we know the emotional and intellectual resilience of children are massively impacted by that, more than probably any other single intervention. The work of our health visitors, school nurses, and further down the line family nurse practitioners is really vital in this, and we tend to focus upon them in relation to physical health issues as opposed to mental health issues. Lambeth, Southwark and Lewisham, I think, have amongst the highest numbers of adverse childhood experiences, and therefore we need to be making sure that all of our services, whether they're mental health or otherwise, are actually trauma-informed, are able to identify and spot those children, so that we can actually make some of these aspirations around early intervention and prevention really work.
Thank you, Mike. And again, there's sort of similar comments, some of Norman's there about actually getting this properly linked with the strategy work and being a part of that, and not, and I understand because this was sort of started in advance, how we bring it together, but Tal.
I think Norman and Mike kind of covered a lot of it. I'm really happy to hear actually someone that leads a massive mental health, trust, talking about community-based support, about how support needs to start much earlier. I think we need to think of community-based support outside of our kind of statutory offer. I think it needs to be based truly within community, delivered by the communities, for the communities, and I think it needs to be representing of the communities that we're there, to support. Yeah, we know young people are more likely to engage and interact with non-statutory services. We know that they're likely to have better outcomes when they do that. We know that those services are likely to be more reflective of the young people themselves. Quite often everything is co-vision, co-design, co-produced and co-delivered with young people at the heart of everything. And I think this is key for me, that everything is done with young people, by young people and for them. So we can be sitting here and talking about things, but young people know best what's best for them. So I think if we want to link it with us trying to tackle inequalities, that the offer that we are thinking of, visioning, needs to be working around intersecting experiences of oppression and discrimination. And we know that we've got big marginalized communities across our 6 places, and we need to make sure that our offer is unique to those unique experiences of those unique groups of young people. And lastly, like holistic, trauma-informed, if we don't do that, it's not going to work. We're going to have revolving doors of young people then turning into adults, coming into our A&Es and coming into our kind of acute mental health services. So everything needs to really be done in a holistic and trauma-informed way. And I tried to summarize really quickly.
That's what I was watching Norman nodding vigorously at just about every word that you said there, Tal. And if you haven't got access to the screen, he has said he very much agrees with your contribution. on that. So I'm going to give the final word on Mr. Kieran.
I mean, I think it's a great piece of work, Martin. I want to thank you to everyone who's doing the work on it. I really want to agree on this point around the long-term ambition, but also the need to focus on making things better as it stands at the moment. So, as a borough in Southwark, we're working to make sure there's mental health provision in every school, and I think we should be having that kind of ambition across the whole of the country, and certainly across the whole of South East London, and also for every parent who needs it as well. I very much echo your point, Norman, about having the right evidence-based provision. I don't know the programme that you talked about well enough, and I'm really interested, is that the one, or are there different, we should be looking at a number of programmes and working out which is the best, but I think we should be clear about that ambition, and we should all be aware that nationally the reality that the majority of children and young people who need mental health services do not get them in the country is a national scandal, actually, and it's something we should be looking to address. I think we need to really have a really strong focus on here in the who is currently missing, though. When you look at the numbers, it's Black, Asian, ethnic minority young people are hugely underrepresented, and certainly in the work we've done locally in my borough, when we set up our open access Nest service, there's a huge contrast between those who are walking through the door of that service and those who are getting CAMHS services. And so I think we just need a really strong focus on who is it that is missing out most now in the working on the current system. That's certainly Black, Asian, ethnic minority communities. I would be fairly confident in saying it's probably disabled young people as well, and those from the LGBTQ plus community as well. So I think if we can have that real focus on who are we missing right now, and I also just wanted to agree with Norman on the bit about transition. I did wonder if that is the right approach. For me, that we definitely need a service for young people that works for them as they go past 18, but is piloting a transition model, supported work, the right model is piloting, expanding the service so it's there for you until you're a bit older, recognising that many 21-year-olds are very much in the same place in their life as many 18-year-olds. So I'd welcome us doing that. But I think that the ambition is the key thing. We won't be able to do all of these overnight. We need national resourcing for some of this work, but getting to a point where there is support for every young person in their school, every parent in their community is going to be really important.
Right, now I'm not going to try and ask you to respond to all you've heard, Martin, but I will ask you some reflections. So I guess the big questions for us, everyone agrees and is supportive of this as a priority. I think where people then challenge is our ambition sufficient on this? How do we do the longer term transformative stuff at the same time as making sure things are not falling over for people now? And linked with that, I guess, how do we properly link that with the strategic work? This is not something that we've just inherited a partnership that was going on and being developed, but is actually part of our strategic priorities now. Any initial reflections from you, Martin? Because I'm probably going to have to ask you to come back, having been to the ICB board about this, well, you've been asked to be ambitious. What could you do?
Yeah, so initial reflections are, I think we're on the journey already on some of the ambition. We are working to work out how we can provide every school with some mental health support, in working in partnership with councils, the schools themselves and the NHS. We just need to work out how we can feasibly do that through evidence-based practice, staffing, digital means, so I think it's work in hand to do that. The empowering patients, parents and empowering communities. We've got great learning, as Sir Norman says. We've worked in Lambeth and Southwark on those models, and we have agreed through the other 4 places that hub model is being rolled out, and we have commissioned and working with our 4 other places, so Bromley, Bexley, Greenwich and Lewisham, to have at least 1 hub in each of those boroughs, and we're working to implement that right now, training parents. So we want to build on that going forward, on top of what places are doing already for parents. I agree about the digital and the Couth and other tools, not for everybody, but it is important. I think for me, we do see this work nesting into the strategic priorities, but I think the bit maybe we want to take away from this conversation is the bit about the model. an ambition for the next 10 years, 5 years about the model, looking at international comparisons, money, investment workflow. I think that would be a useful thing to do through the reference group, but I think we probably need to, maybe with Sir Norman, maybe Doxy's colleagues and others, maybe to have a little deeper conversation about that outside as part of the IPC sponsoring that work as we bring in our work into the strategy, because I think that bit would be good to talk more about.
Okay, can I suggest that then? And I think particularly you have this conversation about that longer term work, because if we only ever think of 1 or 2 years, all we can do is improve the existing model. That's just a given. But maybe have these conversations initially with Norman, potentially with colleagues from Oxley's, but I think also Tal with the voluntary sector and a few of our colleagues from local government about what is how are we going to get to this scale of ambition for 5 and 10 years. And other things, I mean, I take Kieran's point, and I've banged on about this a little bit before. Yeah, why can't we just say as South East London, we will have mental health division in every school in South East London? Just say, why can't we just do it? Because we're probably 75–80% of the way there, and it just gives us something to hang on to on some of these. So just some thoughts on that. Now I'm 15 minutes behind time, but that was really worthwhile again. I'm hoping that Mike Fox's finance session will be equally worthwhile for people, and they will be equally invigorated by this as they have been by strategy and by mental health. But Mike, I'm going to try and keep you to a quarter of an hour if that's all right. Okay, so
thank you for that introduction.
Over to you.
Yeah. I'm sure everyone will be more than invigorated by the new financial strategy, but I'm sure that everyone's read it and enjoyed it in advance. So just some highlights to our observations. Obviously, the ongoing process of developing our medium-term financial strategy is ongoing. I think the bit that we do always say is that the environment that will be in is going to be extremely challenging, not only operationally, but the financial environment that we know we are currently in and moving forward. But we are still reflecting our ambitions as a system in terms of trying to achieve a real tangible shift in how we as a system deploy our resources to address and reduce health inequalities within our communities, but also achieving financial balance overall and financial sustainability within that, and also continue to support mental health investment standard and other investments outside of acute care. Obviously it will be incredibly challenging. The emphasis and challenge for us all will be to ensure that we are getting best value for all our investments and all our money deployed within the system. As a system, we have £4 billion, give or take, that we are responsible for commissioning. It currently stands, but actually when you start looking at our total turnover for our providers as well, from out of area commissioning and specialist commissioning, you're looking at nearly £8 billion, which is a huge amount of money. So how do we get best value for that? But equally, we have to recognise there's going to be an enormous challenge in the years coming forward around the efficiency requirement and agenda for us as a system. We're looking at an efficiency requirement in circa 950 million over the 5 years, with the largest amount in year 1 due to continuing normalisation of funding compared to the long-term plan and the initial impact of that in year 1. Obviously all of this, Chair, will be refined as we get more information about the next 2 years funding allocations, but also the expectations against those funding allocations in terms of elective recovery and recovery of other services. I'm sorry to say that the guidance, especially around elective recovery, is delayed and still not with the NHS at the moment, and that will mean meeting certain planning deadlines for the ICS and ICB extremely challenging in the next 2 months.
Okay, thank you very much, Mike. Just a couple of things from me, just by way of introduction from me to the conversation. And the first thing we try to do here is just to give you a picture of how we deploy our money now and how we deploy it. And it's important the partnership gets that visibility. As Mike says, there's about £8 billion, give or take, on around here. So this is not an insignificant amount of money. And within that, of course, that doesn't include the local authority spending on public health, on social care. So you add this together, you have got a shed load of money. Yeah, may not be enough, but it's a large amount of money. And I think we've got to think really seriously partnership about how to deploy that to best effect. And the second thing I want to point out on this is we're trying to put some stakes in the ground here about shifting resource. So you will see within there particularly our commitment to creating a separate amount of money that will be targeted on reducing health inequalities within South East London, rising to 175 million by the end of the 5-year period. Now, it starts off as a relatively, in the great scheme of things, small amount of money, and you might say that 175 million on about 8 billion quid at the end is a relatively small amount of money. But to most people, if you think about what you could do with 175 million, you could achieve an awful lot with that. And we've been quite clear as an integrated care board now that we want to hold to that commitment. Whatever the pressures are that are coming in from elsewhere about spending on other things, unless you put a stake in the ground and say we're going to hold to that, it will get eaten up with other things. So I think we want to share that with the partnership, because the partnership be quite clear that's what we're doing. But any initial reflections from people on just this sort of look forward? Anything you want to say further, Andrew?
I would, yes, Chair, if that's okay. It just, I don't think it's provocative at all. I just think it's the sort of mathematics of it. So the overall pie, it is getting bigger because we get growth, but it's not really getting bigger in real terms. That's like got a sort of surprise for us. So it does then require to live by the sort of commitment that Richard's made. We've talked about the positive of 175. That's predicated on the return of investment on every pound we spend, and it's also predicated on each of our current providers either changing their models to transform or to be able to be more efficient and live with less. We are essentially redistributing across sectors. I think the paper is quite clear that it's sort of myth-busting this bit around geography so much, but it was more what you do across the sectors. We've talked about mental health, children's young people's mental health particularly. But that's a sort of the ask. So the ICB board, this comes with a real ask on efficiency, a real ask on the system to do things differently, not just in terms of how we spend this 175. So that sort of deal, I guess, is the obvious. Maybe we have to hold each other to account. That's what it means, I think.
And so I will also add the point that Andrew mentioned, a really important one, that we are not seeing within this any requirement to redistribute NHS commission spending in a different way geographically across South East London. If you look across South East London, broadly speaking, people have got their fair share. Now, what you may then get is a differential spending with each borough on different areas where you think that looks odd, but the total pot feels about right by borough. So I think, that not redistributing across boroughs of the NHS spend, a commitment to the 175 million and growing that fund, but an understanding of the expectations from efficiency savings to allow us to do that. I guess that's what we're saying to people today. Does that feel like the right package to you? I'm making sure I look to my left and right, because I've got two sort of hospital chairs to either side of it, so I've been ready to. Sorry, and I had a hand up. Where did I have a hand up? Oh, it was there. Sorry, Flaki. I knew it was at one side. So Flaki first. Mike, Charles, anything you would like to say or not say?
Well, I think that you alluded to the fact that the overall health spending in real terms has not been increased. I think the providers are all in a position whereby they're addressing the problems of structural deficit. And I don't think we should be shy of having to confess and continue to admit that the finance directors that you talk to in our organisations will be telling you that the money down the sofa of balance sheet adjustments to achieve break-even positions is in short supply, and demand isn't. And therefore we have to be realistic, I think, from the point of view of the provider sector, to address the financial circumstances which the provider sector finds itself in, which does not allow for enormous efficiency savings beyond what we're being asked to do by NHS England, whether through the ICB or not, for redistribution. So I just think we need to be quite cautious and realistic in the short term. And from the national point of view, we can all as citizens take a view as to the state of the national finances and how optimistic we can be that growth in real term spending on health and social services and social care is going to happen as we approach what is now already an electoral cycle. And I think, again, realism is the duty of us all, that the figures speak for themselves when you look at the public sector borrowing requirements for December and beyond. So while I think we can violently agree that there is a huge demand in our region, in our ICP and other for adjustments, and indeed with 175 million, not going to quarrel with that at all, Richard, not for 1 second. I just think a dose of realism and about the economic conjuncture that we find ourselves in should be taken into account.
Okay, and we start off on this at 25 million quid in the first year, and partly because of what you said about the pressure. So my personal initial response was we're not ambitious enough at the start. Now, I think that is because I wasn't necessarily given this dose of realism at the start. But Falake.
Thank you, Richard. Thank you, Mike, for the summary as well. I guess we're all very aware of the challenge of finance and what it means and what it will mean for the system and ultimately for people's care. And so I commend the shift to trying to move some money to tackle inequalities very clearly, because I don't think without change we won't get change. We've spent a lot of the morning looking at very ambitious ways of working and talking about doing things differently. We've talked about a broken CAM system. Patients will tell you about lots of other broken systems. And so I personally, and I'm sure many members of the public will say, yay, yippee. But it does mean that if we're going to look at that, we really, really need to have really robust quality impact assessments, carers assessments. We need to do it very strongly alongside the work we're doing. And I know that the ICB is reviewing that, and it would just be good to make sure that it's in tandem, that we recognize when the review of those assessments take place, that they are shared rather publicly, and again, that they involve the voluntary sector, our communities, and our staff in those conversations. That they aren't sometimes the, dare I say, tick-box exercises that they can be, so that we are actually really effectively creating change and reducing inequalities.
So, thank you for that, Ian. Yeah, this is very much going to be not just about the money, it's about how the money is used. Do we really understand the impact? And that's the key message. Mike, finally, unless you. So Mike, Kieran, Charles.
So I think everything you said there are fully endorsed. Notwithstanding Charles' comments about the financial pressures, which I absolutely accept, it is major. There's a couple of principles at stake here. One of them is that over time we shift from a system which spends most of its money on the acute sector to one which spends a greater proportion of its money on community preventative and a whole range of other interventions. I'm happy as a trust chair of 2 hospitals to be saying I fully endorse that approach. When I look around my wards in hospital, 60–70% of those people wouldn't be in there if we'd made earlier interventions, and could be out of there much sooner if we had a range of other packages of care wrapped around them. So I think it's vitally important that we actually shift that investment over time. And 5 years should be long enough for us to manage that transition and put in place some of those preventative and anticipatory healthcare models which are going to allow us to safely reduce the capacity that we currently have devoted in the acute sector. The second area is, like you, Richard, I shared a little bit of disappointment when I saw the level of health inequalities funding initially and felt that we weren't necessarily being ambitious enough. Then I looked at the bottom line of my organisation and thought, okay, maybe 25 million in the first year is about right. It is great to see that we're moving on that, but I think there's also another obligation upon us when we look at the core spending of the rest of that 4 billion, 8 billion pounds, to make sure that every single penny of that is also being directed in a way which supports that broader issue of tackling health inequalities. So yes, a range of special projects to really move the dial, but all of that work needs to be framed in that way. So Mike fully endorsed the piece of work you've done here. And that's a very good point, Mike, actually, because what you don't want is suddenly people say, actually, well, there's a pot of money that does health inequality, so I don't need to bother about that anymore, and that's definitely not where we are. Kieran, then I'll finish with Charles.
As I said, I'll be very brief, but the principle of moving resource into reducing health inequalities is a fundamentally important one for all of us, as is the principle of moving money from acute services to those that are more in the community and more preventative. And there are many reasons for that, but the two most important ones are we have far too many people in our community ending up with serious ill health, whether that's physical or mental, and we'll only turn that round if we're investing in the prevention and the community-based services. And that's the only way we're going to end up with our acute trusts not in incredible financial stress in the long term, albeit I appreciate right now for our residents, people are genuinely worried about being able to go to A&E and get good service or get their elective care treatment that they need and not being on a long waiting list. So it's going to be very hard, but we have to have those two principles.
Charles, 2 quick points. One is that just to remind us all that there is a thing out there called capital funding as well, which is not what we've been talking about here, which is revenue funding. And since the legislation that came in, which gave rise to us all sitting here today, also confirmed the severe limitations of CEDEL on providers. All providers across the country, not only in London and South East London, are labouring under the difficulty of not even being able to finance remedial replacement capital of the existing estates, let alone new investment in provision. So I think all trusts, all provider trusts, whether they're acute or not, will be under pressure to maintain some form of capacity to invest in services for across the community. So I just want to remind everybody that there is a capital issue as well as a revenue issue. But secondly, to the point that Mike is making, I think it's beholden on the whole acute provider and hospitals, teaching hospital provider sector to participate in this redistribution, not simply sit outside it. So what I mean by that is already our trusts are assisting our friends in primary care, in community hospitals, and across the piece. And therefore, I think it's the dichotomy, the division, if you like, between what is described as the acute provider sector and the other providers of social and healthcare across our communities has got to be examined from the acute provider point of view as to what more we can do, not what fortress we can build and what drawbridges we can pull up, and leave that to the ICS to deal with everything else.
Thank you very much, Charles, because that's exactly what we want. Now, I have in the time that others have been talking, I think I've got 3 more people who want to come in. So I'll start off with you, Catherine.
Thank you. Catherine Bremer, Director of Public Health. Just 2 quick points. One, all of this is, as a public health person, music to my ears about the investment in prevention and health inequalities. The second point, I think the challenge from Andrew and Falake about demonstration of impact, we will be working as public health colleagues with academics, so on and so forth, to make sure that what we're investing in health inequalities is having the impact required.
Okay, thank you very much. And we've got that impact. Yeah, we do understand that question about impact, I think, and we have got the techniques to do it. It's just we don't always find. So I'm going to have Gavin, then I'm going to allow Andrew the last couple of seconds on this.
Yeah, I think to your point, Charles, I definitely agree. And I think if you look at the CMHT Community Mental Health Transformation Programme, it was been a big success there because of the way the funding was arranged in the sense that 50% of the ARS came from primary care and 50% came from the community mental health trusts. That meant that both parties were round the table together, looking at the funding together in equal footing. So I completely agree with what you're saying, Giles. I think if we make sure we arrange the funding in that way, so there's a joint commitment from both sides, then actually we'll have a better joined up working. And also regarding the comment about outcome measures, I'm very nervous about the kind of continuing with the same outcome measures going forward. Because as you transform and change the services, there's naturally going to be a challenge in maintaining that. And I'd like to see us measuring what we want to see happen, which is joined up integrated working, rather than continuing with the same clinical outcome measures.
So can we come back on the measures issue, Gavin, I think later, because we've had this bit before about the outcome measures or the measures of integrated working, but I think it sounds a bit techy, but I think it's worth us looking at. But Andrew, you want to come back?
Just hopefully not a cheeky point, Chair. I've learned huge amounts since we've worked together around negotiating techniques, and I just want to make sure that in terms of the numbers we talk about, we're trying to have some different numbers around today, but the numbers we call in the paper are the amounts that I'm committing to as a council officer, because we've grown some commitments over the course of the conversation. We've reduced them again, so we've got 135 million over the 5 years is our total commitment.
175.
You added 40.
I thought you were being very generous.
Just to make sure it's like an average behind my back. So that's
sorry, some numbers in the paper. I clearly remembered numbers that I wanted. Numbers I was given, but that is not.
It was suspiciously close to the number you would ask for, yes.
That's not unusual. Yes, sorry, I take that correct. So thank you for that. I mean, that was a good discussion. I think people sort of welcomed the sharing of the information. I think agreed the numbers that my chief executive told me were in the paper, not the ones that I made up. And I sort of agreed to principles approach. A real focus, I think, just on this, we've got to make sure we measure impact of this, and we've got to make sure we measure that properly. That we've not got to somehow sort of almost ghettoise health inequality and say this is money for that, so we don't do it elsewhere. Health inequality, we've got to put all of it. We've got to be realistic about what can be squeezed out of our provider sector, and squeeze out in relative terms, because whatever happens, the numbers we are spending in the provider sector are going up each year, so let's not pretend that we're reducing those numbers. They're not going as fast as people want or as fast as demand, but they're going up. But let's be realistic about, there is something about the capital side that we may return to at a future time, Charles, because we have had a bit of a conversation within the ICB about do we make the best use of the estate across South East London when we look at what we've got in primary care, what we've got in community care, what we've got in acute sector, what we've got in local government. If you put it all together, what does this look like, and do we make enough of it? But that probably for another day. So thank you for that. At which point we're going to move on to social care. I think, Sarah, you're going to sort of effectively give us a bit of a taster on this, just trying to sort of explain current position, challenges, and a bit of a forward look. So I'll hand over to you at that point.
Thank you, Richard. So I'm Sarah McClinton. I'm the Place Executive Lead for Greenwich and also the Director for Health and Adults in Greenwich. So thank you, Richard, for the opportunity to have a bit of a focus on social care, particularly adult social care, within the context of those broader system pressures that we're all very familiar with. And the breadth of social care across support for people with mental health needs, older people, learning disabilities, as we know, are just part of those broader responsibilities that local government have in public health and children's services as well. And I guess one of the opportunities that the ICS brings is the strengthening of those partnerships across local government and the NHS in ways that does enable us to work together to improve health and well-being and outcomes for people. And hopefully the paper kind of resonates a bit with some of that conversation we've just had around the MTFS and the need to shift our thinking to prevention and early intervention and support in people's homes. So we've heard a lot about kind of pressures and the context that we're in now through Sarah's update earlier. And we hear quite a lot about social care in the media. Constantly, I hear this very strong narrative that there are 14 100,000 people waiting in hospitals for social care. And I think it's really important that we understand that that isn't the case, and it's probably less than half those people are actually waiting for social care and support. There's delays can be as a result of some of the processes that we have in our hospitals, but really importantly, it's also people waiting for NHS support in their own homes, in communities, be that vital therapies or district nurses, or people waiting for continuing healthcare. So I think it's important to recognise that. And that means that we really do need to work across the system and work in more joined up ways if we're going to be able to provide the right care that's right for people at the right place at the right time. So I won't go through the paper, but just say something about the money. We've already heard about the unsatisfactory nature of short-term funding coming at the last minute, and we had the 500 million that was announced not very long before Christmas, very quickly followed, I think before we'd done our first return on the 500 million, this 200 million. So I won't rehearse all of that, but what the paper does do is, looking ahead, set out the autumn settlement and what that means in terms of social care grants, how that translates locally. But I think it's important to recognise that some of that money is across children and adults. It's not all for adult social care. And as local authorities and leaders, you'll be working through what that means locally at the moment in terms of local authorities' medium-term financial strategies and setting budgets for next year. I suppose I wanted to highlight that the focus on discharge, and we're all obviously committed to working together to try and make sure that people can leave hospital in a timely manner into the appropriate support arrangements. But there are two consequences, I think, if we focus on discharge at the expense of everything else. And we've heard already about the kind of increased pressures and activity in the systems, but one of the consequences is that we are seeing significantly more activity in local authorities in our adult social care systems as well. So, for example, the report sets out how the councils have stepped up, and the amount of home care being provided has increased by between 16 and 35% in the 6 boroughs across South East London. That obviously also then has an impact on local authority budgets. It's perhaps important to understand that roughly 67% of the council's budget is spent on social care. That's across adults and children's, and also people will understand that councils have to set a legally balanced budget, and they're not able to overspend. So there are real kind of pressures that we're experiencing at the moment. And I think if we don't focus our efforts on reablement and recovery services, then we're going to continue to see those pressures grow in a way which is going to be unaffordable and unsustainable. I think the second thing about that we need to recognise in terms of discharge is it's actually a very small part of our overall responsibilities as directors of adult social services. From April, directors will all be having to pay attention to the fact that CQC will be assuring local authorities, and they'll be assuring local authorities and their social care services across all of their Care Act duties, discharge being, as I said, a relatively small part of that. So that's another part of our context. And as you can see in the paper, I think it's page 92, there are actually over 8,000 people across South East London who are currently waiting for some kind of care and support in communities. So many of those people will be at risk of deteriorating health. Some of them will reach crisis point, be that carers who can no longer cope, or people's health deteriorating to the point where their care arrangements break down and they're propelled into higher levels of care. All people will need to go into hospital. So we're in this kind of vicious cycle where if we're not able to support people in their own homes at an earlier stage, then actually their needs increase, and that puts more pressure on other parts of the system. So we're seeing a real impact of those pressures in the NHS, both on our activity levels, but also that focus on the acute means that people in the community are missing out, and that point about health inequalities also therefore being exacerbated. So then I wanted to do a bit of kind of looking ahead, and Andrew sort of mentioned capacity issues earlier. So thinking about how we plan and ahead and think about our capacity and how that fits within our broader sort of whole systems at place and South East London level. There are a few things really just to say. So in terms of care homes, I would start by saying that actually less than 3% of people who leave hospital needing care and support actually need a care home. So I think we really need to focus our attention on the support that people have in their own homes. But in relation to our capacity across South East London, it's not that we don't have capacity in our care homes, but I think that the issue for us is about the complexity and acuity of people's needs and how we can find the right settings for people where they have the right appropriate levels of skill and support. So that, I guess it comes back to the whole systems, that wraparound support that care homes have in terms of mental health support. Often we're talking particularly about people with dementia. So the primary care, medical and wraparound support to care homes is going to be really important if we're able to respond to those levels of complexity, or the providers, the social care providers are able to meet those very complex needs, but also to manage people's conditions in a more proactive way and reduce people having to, what's essentially leaving their home to go to hospital, if that is something that can be managed with the right support in a care home. So that's one of the things I think that we can look at doing better for the future. And then we also across South East London have very good capacity in terms of our home care services. We have a pretty vibrant market, lots of providers starting up, as well as some very established providers. That's not the case in all parts of the country. But again, I think the challenge is really how we upskill some of those workers and how we make sure that people in their own homes not only have home care support, but the right support from community health services as well. And how we address some of those issues around skills and pay, etc., in the social care sector. So I think just to kind of reiterate that point that the capacity can't be never ending, and that focus on reablement and recovery, which really is a spectrum of services across health and social care, we need to are really critical in terms of managing those overall needs of our populations. And if we don't allow people that support to really recover and regain their independence, and that's really important in terms of people achieving their best outcomes, but it's also important for a sustainable system. So that's why one of the recommendations coming out of the paper is that might be an area that we want to focus on in terms of what are the optimal models that we've got across South East London, and how perhaps do we learn from each other and standardise some of that. So finally, funding is always welcome, obviously, but actually it's workforce that's our biggest rate limiting factor at the moment. So I think we really need to think about our care workforce as we're thinking about the broader workforce and people plan for the ICS. And how do we address some of those issues about pay and career development within the social care workforce? It doesn't take 7 years to train somebody to work in social care, so there's actually lots of capacity in our communities that we can and assets that we can build on in order to develop that workforce, but also enable people to develop their careers across health and care. So I'll kind of stop there. The recommendations are really recognising there's probably more that we can do across South East London. There's some data in the paper. It's probably our first go at pulling together some of that data. So it comes with a bit of a health warning, but I think there's more that we can do to develop the data in a more consistent way across the 6 local authorities. And as I say, more we can do to think about what are the optimal models for reablement and recovery, what are those sort of opportunities for integration in that space particularly, and even things like what's the support offer into care homes, and how do we make sure that again that is consistent across South East London. I'll stop now.
Thank you very much. That was very helpful, and very helpful bits of sort of myth busting in there as well as other stuff. I mean, I mean, your comments on capacity, I guess, came as a bit of a surprise to me. I mean, not quite as bluntly as we haven't got a problem with care home capacity. We haven't got a problem with home care support in terms of capacity. I mean, you were quite specific on those, which I just thought Margaret was very interesting. But you also put sort of 3 particular recommendations in the paper that I do want to say either yay or nay to as us sponsoring as a partnership. One is this improving the data and having a system-wide data set and dashboard that we can then look across each of our boroughs, and we can all share this and see what's happened. This sort of sharing of approaches on optimising service model, just thinking, well, what can we learn from each other across the boroughs, seems very sensible to me. And actually bringing the social care workforce more centrally into the ICS people strategy. Now, all 3 of those seem to me to be sensible recommendations to be making, but I will just check and look for nods or shakes of head on that, which we can then sort of agree to. But then any sort of further points or questions? Andy.
If I may please, Andy Trush, I'm the chair of Oxley's Mental Health, Community Health, and also chair of London Ambulance Service. So he did mention the figures, but I wouldn't mind that 3% that you were talking about, because quite clearly in the national discourse is that if only the social care was working properly, it would open up the acute wards and everything would be fine. Could you just expand on that so I've got it right? What you just said?
Yeah, so the 3% I was referring to is if you look at the data that is collected nationally over the last few years, it's less than 3% of people who leave hospital with social care support who actually need a care home. Most people, I'm arguing, can be supported in their own homes if there's the right capacity and support available across social care, but also community services to enable that to happen. That's not to say that some people can't benefit from some step down, some opportunity if the longer term arrangements can't. So discharge to assess obviously, can take place in a short term placement. Whilst people work through what's the longer term right thing for that individual, for that person.
As I was just thinking about, of the ones who are waiting to come out, what sort of percentage would need social care? It was 3% as a...
Yeah, so I'm talking about a care home. So care homes is just what I'm trying... care homes are part of what social care does, and often social care is seen through the lens of care homes, but actually most people are supported in their own homes, in their own communities, and that home first principle is really important. In terms of discharges, less than half the people who are don't meet the criteria to reside would be delayed because they're waiting for social care. There are lots of other reasons why they may be delayed.
Okay,
yeah, and it's historically been less than half of that.
Yeah,
we call for quite a long time. Now I have got definitely questions from Kieran, from Norman, from Jill, from Gavin, and from Jim. Now I'm going to do all of those at once because I am conscious that I know people will have to leave, and we just say a little bit about public questions. So I started off with you, Kieran, didn't I?
So a comment and a question. So your paper helpfully sets out the financial situation. I think it's worth for everyone being very clear on the local government settlement. While there's some relatively positive news about funding for the coming year for social care, what has in effect happened is that money that was originally intended to introduce the improved social care national offer for residents has been used to cover inflation. And so it is no longer clear where the money for the future reforms come from, because it's just been put into the pot. And so that obviously allows us to deal with the current inflation situation in a better way than we thought we might have had to. But we are now not sure how we'll be able to fund any improvements in the future and in the long term. And it's also dependent on increases in council tax, which is not the best way to be funding social care. So that's important to say and be clear about that. But I was really interested in your point, Sarah, about workforce that comes through so clearly in here. And I guess my question is, if we were being really ambitious about creating the right pathways for our residents across South East London to get into care and then maybe move on to social work, or maybe move on to being a nurse or a paramedic, what do you think we could do that would really be genuinely ambitious, and help us meet the needs that we've got in the system at the moment.
Norman.
Thank you. Two quick points. But first, I very much agree with what you want to funding desperately need a settlement of social care nationally. But while we wait, I very much agree with the three proposals from Sarah. The key point to make is on the second one on optimising service models, that we absolutely extend this to mental health, because there is the potential for so much improvement by closer collaboration on keeping people out of hospital and on timely discharge if NHS and local government could work more effectively together. Thank you.
Thank you, Norman. Jill?
Thank you, Sarah. It's excellent, really helpful. Just 3 points from me. So, one, agreement, re-ablement, workforce, dashboards, lovely, very keen to help on that. Just in terms of help, there is a wing of the public policy, social policy element of King's College London that focuses on workforce around the social care sector, and I'm sure they would be delighted to join in some of the thinking with you. And then the third piece is just slightly tangential. If we're going to develop a dashboard in the way that Sarah's described, should we also think about housing? So if we're thinking about the front line, and if we're thinking about reducing inequality, housing is the true front line. I was quite inspired by the Local Government Association paper on high impact changes in housing and how to transform inequality through housing. And I wonder if we could bring some of that here and think about how it fits together, both the health and social care piece.
Okay, let's think about how we could bring some of the housing issues back here, because it's come from quite a few people. So, Gavin and Jim, yeah? Gavin.
Just firstly, to speak to your point, Andy, I think from what I can gather from what you said is that there's 8,000 people in South East London currently waiting for social care at home. I think rather than focusing on the discharge, sort of backing up or clogging, that's 8,000 people, and I'm interested to know how long they're waiting for social care. That's 8,000 people, probably for many months, sort of languishing, and then therefore they're attending primary care, attending A&E, more likely to be admitted, and then obviously they have a knock-on effect for blocking discharge. So a quick question, if it's possible, the length of time people are waiting on that waiting list. And the previous remarks made about the workforce, I would be encouraged and would like to encourage if we could bring them more into primary and community care. So the more they feel part of and supported by the healthcare professionals that work within the NHS, the more likely they are to recruit and retain them, but also the more likely they are to be able to be effective in their role.
Thank you. Jim?
Yeah, thanks very much. Great paper. Obviously, the position is probably in the medium term even more pressurised than we might understand from the paper. We all see our ONS numbers coming back showing real significant increase in over 60s, and that's obviously in the medium term going to build up demand even more. Completely agree with the 3 priorities. I just want to make a plea for both on the optimisation of the service models and the workforce that we include London Living Wage as a key component in that. If we don't address pay, 1, we won't address the workforce problems, but 2, we won't start to address some of the wider issues around social determinants that we know are crucial. So could we just have that flagged up in everything we do?
Thank you. And just any quick reflections back from people?
Do you want me to be very quick?
Sarah,
on those workforce things, so there is some money from the GLA to establish a hub. That absolutely, I think all of the DASs would support the aspirations around pay. So I think there is more we can do with apprenticeships, etc. I won't go into the detail, but absolutely we're working together on that. Hello, Norman, and yes, absolutely mental health, and very interested in the work you're doing across London, and perhaps we can think about how we take that forward with some specific work in South East London. I won't go through everyone's comments, but yeah, I mean, and the comments.
So we've got quite a lot to take away there, but we have accepted your 3 recommendations as well. Now, I am conscious I am at my close time now. I'm going to summarise the best I can in a minute. Ben, we had a number of questions from the public in writing. Now, my proposal is we've got responses to those in writing. We put those on the website. I don't think we need to read them out. Have we any questions from members of the public here today that are present? The gentleman in the far left.
Thank you, Chair. I'm from Health Watch. Just picking up the conversation running through the meeting and mentioned by King's Health Partners. There is an underrunning theme around housing, which impacts across all of this. And I was pleased to hear that at the end. National guidance indicates that housing providers, housing associations, should have a bigger presence within the ICP than I think currently exists. Whether it's a seat at this specific table or some sort of conversation, because I think all of the conversations this morning, plus some of the conversations around finance, which would be considerably aided if housing associations are more integrally involved. There's some good examples nationally of the work that they're actually doing, and in a funding context within their social responsibilities, they do work as well. And in a global context, we've just started a conversation with housing providers, but they work right across the ICS footprint. So I don't know if moving forward there could be a focused conversation or piece of work in that regard.
Yeah, thank you for that. I'll give my answer there. I will let my co-chair comment. Yeah, I think we have got to bring housing into this conversation a lot more than we have. We haven't actually put a housing provider around the table, partly because when we set this up, we're looking at how many people can you have around the table and how do you, that doesn't mean that it's not important to us, and I think we should bring a proper conversation about housing and the impact and what we could do differently to one of these future meetings. I did, just as an aside, on the Integrated Care Board, the other three-letter acronym, I did deliberately bring a non-executive director on that is currently a housing director in London, to try and bring a bit of housing thinking into around my board table. Kieran,
okay. Obviously, I want to agree that housing is fundamentally important to people's health, and whether that's the impact of having a good quality home has in maintaining your health, whether it's the role of housing and discharge from hospital, or indeed whether it's about homes for social workers and nurses who are struggling to live in our boroughs. All of that spectrum is really important. You have got some very big housing providers around this table. So as Southwark Council, we have 36,000 council homes, probably the biggest landlord in South East London. Other councils are also major landlords, but I do agree in a conversation with housing associations as well on the board is important. So we should look at how we do that well. Thank you for the question.
Okay, thank you very much then. Thank you very much, Tam. We've been through a lot of stuff today. Hopefully, I think this meeting has sort of moved us on the stage. We firmed up on the strategy. We've been clear about the next steps on that. We've got into really strong conversations, I think, about our scale of ambition across all our different areas, whether it's on children's mental health, or on how we shift money about the system. And we started to open up some of the conversation about social care as well, and how we link this more into the conversation we're having. Sometimes it looks a bit too much just like it's an NHS one. So I think we made a good step forward. Kieran will take us a step even further at the next meeting, but thank you very much for your time today. Thank you.
Thanks a lot.